I am Toyosi Onwuemene. I am a hematologist and I specialize in disorders of bleeding and clotting or disordered hemostasis and thrombosis. Today, I want to talk about the thrombophilia workup, also known as the hypercoagulable workup. And I feel like it's important to talk about it because people ask all the time, Dr. Onwuemene, when should you get a thrombophilia workup? And you may have heard that you get a thrombophilia workup when you are not sure why the patient had a thrombotic episode. Okay, for instance, a young person, otherwise healthy, comes into the hospital and they have massive PE or they have massive DVT, so pulmonary embolism or deep venous thrombosis. And the question invariably is, this person is super young. How could they have a massive pulmonary embolism or a massive deep venous thrombosis? We should do a hypercoagulable workup to figure it out. All right, so I think the question is when do you do a thrombophilia workup or not? The answer is usually it depends. But more often than not, you're better off not doing the thrombophilia workup. And we'll talk about why. All right. Usually this happens when a patient is in the hospital and they come in acutely with a massive PE, pulmonary embolism, or DVT, deep venous thrombosis. And people are like, I just don't even know why that happened. And they say, let's do a thrombophilia workup. Here are some of the issues with doing a thrombophilia workup in the hospital. Now, anytime you have massive thrombosis, you're going to have responses and lab abnormalities that are related to having the massive thrombosis. For example, your protein C or protein S could be decreased in the setting of massive thrombosis. Antithrombin activity levels could be decreased in the setting of being on therapeutic anticoagulation. Protein C or protein S could be decreased in a patient, say, who's on warfarin. There are many things that impact the results that we're getting. For that reason, it is really best to save the thrombophilia workup for a future time rather than trying to get it in the hospital. Because number one, it's not going to change your management. A patient who comes in the hospital with a massive DVT or PE needs therapeutic anticoagulation. And there is no thrombophilia workup that's going to get you off the hook. You're not going to be able to say, wow, the thrombophilia workup is negative. The patient does not need anticoagulation. That's not going to happen. For that reason, you want to not do testing that you're not going to make management changes for. And another thing is a lot of this testing takes time to come back. And so I always wonder about the utility of sending testing that you're not actually going to be able to follow up on. And that can be kind of frustrating, especially to me, the hematologist, when I see these patients on the outside or when I see them in the future in the hospital, where someone will say there is a history in the chart of protein C or protein S deficiency. And I'm like, protein C or protein S deficiency? Are you sure? And that is usually what happens when there's a whole lot going on. Patients are on anticoagulation and the tests are drawn. And people in the future can't tell why the tests were drawn or under what circumstances they were drawn. And sometimes they come to erroneous conclusions. And so that's where you get the urban legend of a patient with both protein C and S deficiency, which is very rare, by the way. But that can happen when these tests are inappropriately ordered. Okay, so I think the take-home message is if you're not going to change your management decision on the basis of the thrombophilia workup, it's best to save it for the hematologist on the outpatient setting, in the outpatient setting. Okay, when would I think about doing a thrombophilia workup in the hospital? I do sometimes do a thrombophilia workup in the hospital, but I do a limited thrombophilia workup. And the one set of tests that I tend to order are the tests looking for antiphospholipid antibody syndrome. And that's APLS. And the reason I look for these tests is because if there is concern for antiphospholipid antibody syndrome, I might change my management. I might reach for a different anticoagulant. I might reach for warfarin. Okay, so that is a test that's going to change my management decision. And that's a test that I think would be reasonable to send in the inpatient setting. Here's a caveat though. In order to make the diagnosis of antiphospholipid antibody syndrome, you do need to have these tests be positive at least within 12 weeks of each other. And so you can't make a diagnosis the first time you send the testing. But if the anticardiolipin antibodies are positive, significantly so, or if the anti-beta 2 glycoprotein 1 antibodies are hugely positive, that might make me pause and think, even though it hasn't been 12 weeks yet, I'm pretty concerned. I might put the patient on a vitamin K antagonist or warfarin. So that's one reason in which I think it might be useful to do thrombophilia testing. Now, the lupus anticoagulant panel could be falsely positive in the setting of being a therapeutic anticoagulation. And so you just want to be careful if and when you send these tests to interpret them appropriately and to make documentation in the chart so that people know what these test results really mean. The best time to do a thrombophilia workup is really in the outpatient setting when you're nearing the end of the decision to therapeutically anticoagulate the patient. At that time, then you really want to ask the question, are we going to stop anticoagulation? And the thrombophilia panel could be helpful to you in making that decision when reassuring the patient or not reassuring the patient about the utility of stopping therapeutic anticoagulation. And that is a setting in which most of the thrombophilia testing is recommended by me. One thing I do want people to consider when we're sending all this testing, one of the things we do is we send genetic testing. So we send genetic testing for factor V Leiden, and we send genetic testing for the prothrombin gene mutation. And here's the thing about genetic testing. Genetic testing and the results of genetic testing have implications for the patient that extend beyond the patient. In many other domains, we do genetic testing after we've done genetic counseling. We say, hey, the results of this test could possibly change your life. Are you ready? Are you ready for the implications? Sometimes for women who are found to have a genetic clotting disorder, they may be denied oral contraceptives. That's a big deal. You want to prepare patients. And so I really recommend that in the inpatient setting, when these patients are presenting for the first time, you're careful about whether you really need the genetic testing, the genetic thrombophilia testing, and if you're going to do it, make sure that you've counseled the patient appropriately. All right, so that's about all that I want to say with thrombophilia testing. In general, it's really not going to change your management in the acute setting where a patient has to be on therapeutic anticoagulation. It's really going to be most useful in the outpatient setting when you're thinking about whether you should stop anticoagulation or not, or whether you should continue anticoagulation at a lower dose. The implication of genetic testing can be significant for patients, and you want to make sure you're having these conversations with your patients. And acute thrombosis can make all the tests come out awry. And so you want to make sure that when you are doing this testing, you can appropriately interpret the test results for future people who don't know what happened at the time that you sent the results. Finally, I do think it's important if you're doing thrombophilia testing to talk with your friendly neighborhood hematologist so that you're not sending testing that's not needed or not interpretable at the time. All right, that's all I have to say today about thrombophilia testing. I would say strongly consider if it changes your management and whether it should be sent in the inpatient setting where there is the potential for it to be misunderstood or misinterpreted. All right, thanks for listening. I'll talk to you next time.